Just giving everybody a couple of minutes to log in and get in. Well, it's been a few weeks, folks. This is Brandon Garrett with the National Minority Equality Forum. Just excited to rejoin everyone today. I'm honored to have our advisory board member, Dr. Ulysses Burley, lead today's discussion on the impact of COVID-19 in the US HIV epidemic. He and the panelists that we have here are the experts. So I'm just going to turn it over to him and let him lead the conversation. I'll just do a quick housekeeping. If you have any questions for the panel, please put it in the Q&A box. And if you just kind of want to chat or put notes in there, use the chat box. And without further ado, Dr. Burley.
Thank you, Brandon. Good morning to some and good afternoon to others. And welcome to this 2022 webinar series hosted by the National Minority Equality Forum. As Brandon mentioned, I am Dr. Ulysses Burley, founder of UBtheCure LLC, a Chicago-based organization that operates at the intersection of faith, health, and human rights. I also serve as project director of the HIV Vaccine Trials Network Faith Initiative. And I'm a member of the NMQF Advisory Board and proud recipient of the inaugural NMQF 40 Under 40 Minority Health Leaders Award. It's my pleasure to moderate our discussion today on the impact of COVID-19 on the US HIV epidemic and the ways in which community-based organizations are advocating for increased funding at the federal level, specifically for minoritized communities disproportionately impacted by both COVID-19 and HIV. In 2 days, on June 5th, we will recognize the 41st year since the discovery of acquired immunodeficiency syndrome, AIDS, which we later learned is caused by the human immunodeficiency virus, HIV. Since its identification, more than 38 million people have died from HIV-related illness worldwide, with 37 million people currently living with HIV. In the US, an estimated 1.2 million people are currently living with HIV, with an average of 40,000 new transmissions annually. Nearly half of all people living with HIV and almost half of new cases are among Black people, particularly in the southern region of the United States. And so I'm pleased this morning to be joined by an all-star panel of Black HIV public health practitioners and advocates, including Dázon, Dixon, Diallo, who is founder and president of Sister Love, Inc., Kurt D. Myers, who is founder and chief executive officer of Abounding Prosperity, Inc., and Dr. Ya Simpson, who is an epidemiologist at the Association of Clinical Trial Services. Together, they will help us to raise public and policymaker awareness of the impact of COVID-19 on HIV. They will help us to highlight the critical role of community-based organizations play in reaching our collective ending the HIV epidemic goals. And finally, they will amplify the HIV appropriations requests and community advocacy efforts taking place in our country. Without any further ado, let's get right into our conversation. Dr. Ya, as our resident epidemiologist, tell us, how has COVID-19 impacted HIV testing, care, and prevention efforts for key populations?
Absolutely. First of all, thank you all so much for inviting me. All praises to that which has created the Son, created us, and we come here in the right spirit with the right order. Let me just start off by saying, still working on the doctors, but I appreciate the push. Let's get into this. So as a community epidemiologist, I'm Sister Ya, your favorite community epidemiologist. And if I'm not, I will become that. And I bring the science to the people. That is what the Association of Clinical Trial Services is all about. And bringing that science, yes, we talk the big talk of data, but I am not your typical epidemiologist. I don't talk about data for the numbers. I talk about it for the spirit so that we can make better decisions and hopefully have better insights. The numbers mean nothing if we don't use it correctly. So I'm not going to tell you how many cases of COVID is over 3 million in the United States alone, over more than 10% have had death cases due to this, and it has impacted Black people as all things, if you just read, just like HIV. We're still higher numbers of death cases in COVID. We're still higher numbers of people that are hospitalized, and we're still higher numbers of people who are what we're calling now long COVID. You all we haven't even dealt with that. So I'm bringing that science to you. What does that really mean? That means we've had several pandemics. The first pandemic has been the longest one, which is the pandemic of racism. That was another one of my articles that another one I put out early on in the in COVID being released, was the pandemic of COVID and racism. But racism's got that trumped, and it has had the most devastating impact on us as Black people, as Africans living in this country. The other aspect of pandemic is, as you just read, Dr. Ulysses, HIV as we know it today. You know, the human immunodeficiency virus as we know it, we used to call it AIDS. However, that terminology, we know HIV. That pandemic has also impacted Black African people around the globe. So is it us or what? It doesn't matter what virus, ailment, disease, it always impacts us the most. As I've heard people say, they get a cold, we get the flu. They get the flu, we die. You know, every time something go wrong with culture, others, we suffer the most, and it is no different with COVID. So when you ask me the impact, it is the same impact as been for every disease out here. I'll bet the opiate issue took a little longer to get to, but as that's ensuing, we increasing in that too. So it seems as though our life expectancy, our quality of life is always impacted by these health modalities. Our, as they would call this, you know, our social determinants of health are never in line for us to have a better quality of life. We, in our aspect of living in the United States, have a lower life expectancy than any other group in the United States as Black people, especially Black men. So the impact is the same. COVID is impacting us because, one, we started testing late. Two, by the time they got to the vaccines, they weren't rolled out as the same. Three, we all don't trust them vaccines, so let's just tell the truth about it. There's both sides of my people. Some are for it, some are against it. In the end, what is the vaccine supposed to do? Prevent you from getting COVID, so it's not doing that. Let's just tell the truth. And even the vaccine makers will tell you it is not preventing anyone from getting COVID, but we do talk about severe, you know, cases, and we talk about hospitalizations. When we look at the numbers of hospitalizations from people who have been impacted by COVID, we see higher numbers of Blacks that were involved, and majority of the time they had underlying health conditions. So that's another very key aspect. Why do we have underlying health conditions? Because we've been having them living in this country. As we had a little conversation earlier about our hypertension, our diabetes, even our dental care. All of that has an impact with us in our care. And in the end, between the vaccinations, we're not even getting to the point of the treatment plans. We are not taking the upticks of treatment that has now been promoted and is effective, by the way, and not stopping you from getting COVID, but it is stopping from or helping to prevent some of the deaths. So what I have just tried to lay out to you without giving you numbers to swirl your head or impress you, I need you to get to the social determinants of why we're talking about this. Because no matter what disease or illness or virus I pick, Black folks are not doing well. And that's measured through life expectancy. We are not living as long as other cultural others in this country, in none of our states and none of our areas where we reside mostly on average. That is the problem, and that is what we need to unpack.
Thank you for that, Sister Yai. So she's really laid out well for us why Black people have been disproportionately impacted by COVID-19 and the social determinants of health that have played a role in not only hospitalizations and death, but also people's access to vaccines, which we know were designed not to wholly prevent COVID-19, or the virus that causes COVID-19 disease, but to prevent from severe illness and death. And so we continue to see a pandemic in our country that is disproportionately impacting Black and brown people. And we see that happening also in the areas in which Black and brown people are overburdened by HIV. And so Kirk and Dázon, you all are both in the South, you all are both leading organizations that connect people to services, organizations that provide education and information, organizations that link people to care. Tell us a bit about how COVID-19 has impacted HIV treatment, care, and delivery from your point of view.
Go ahead, Dázon. Ladies first.
Sure. Well, I'll take that for now. We'll make sure we have gender agreements in the future. Ha! So we'll all be fair to each other.
There we go.
Yeah. So thank you all for the invitation. It's exciting to be here.
So beauty over age then. How about that?
That one, you know what? I ain't even gonna fight you on that. So I'm going to take a moment just to say thank you. It's always a privilege to hear Mama Ya deliver her thoughts and her insight on a lot of these key issues from a different epidemiological perspective. At Sister Love, we also look at things uniquely and differently. Most of the work that we do with regard to sexual health, sexual and reproductive health rights and justice is just that. It's from an intersectional lens of looking at healthcare in terms of access and services, acceptability, affordability, placement, all of that kind of accessibility. It's also about looking at the legal protections, resources, the equality that has to go into making sure that folks have the appropriate protection and promotion of their rights, that they know their rights and that they're able to act on those rights to receive those services that they need. And then of course, third to that is justice, which is the equity. And at the beginning of the new day, I don't want to talk about the end of the day because it seems like the day never ends. At the beginning of the new day is when we actually achieve liberation. And a liberation would be the marker with which we can then measure the disproportionate impacts of all kinds of pandemics, epidemics, and disease states among people of African descent in the US and worldwide. So having said that, intersectionality being a key focus for us from a Sister Love standpoint and from a Southern standpoint, it's not as if we weren't already clearly aware that the policies, the practices, the regulations, the way that people operate, even inside our own spaces, our allies, our comrades, our co-conspirators, is that implicit bias, racist judgment, racial systems, systemic racism, all of that undergirds. When people say, why are you always talking about race? Because it's always about race. It is always about this false construct of somebody having privilege and power over others based on the color of their skin or where they're from or who they're from. That is the crux of so much of our conversation that is very difficult to get to people to understanding why HIV, why COVID-19, why Black people are the most homeless in this country. The state of California just published a racial justice report. If you all haven't seen that, one of the bluest states in the nation that has a report about the abject engagement it has had over the centuries, at least even just since the 19th century, in terms of racism and systemic racism in an anti-Black context. And let's be clear, there's lots of different racial injustices, but there's nothing like the anti-Black racial injustice that happens in the US and around the world by far. So when the COVID-19 or when the SARS-CoV-2, also known as coronavirus, I also think it's important to educate people about the difference in that, the same way we've had to educate about the difference between HIV and AIDS, right? COVID-19 is sort of like the AIDS part of the story. It's what happens after you've been exposed and after you have had a transmission and after you have had reactions to that end up in illness. The coronavirus situation is something that we could have had our eye on for a very long time if we understood its connections to our immunology and our epidemiology with regard to our respiratory diseases, with regard to our heart diseases, and with regard to our sexual health diseases, quite frankly. Just keep your eye on monkeypox and see what happens. So I'm saying all of this to say that it shouldn't be a surprise to people that, as Yah says, when COVID came along, we should have already known and been ready for the onslaught that was going to happen. It's our next Katrina, just like HIV is our slow Katrina, that where we are in trouble, we will be the last to be rescued. Where we are in dire straits, we are the first we have to turn to save ourselves. So the first thing we did, just to close this out, was we knew that, one, our organization was going to have to continue doing what it needed to do, regardless of the constraints we were having to do it in. So we immediately, as soon as a test was available for the coronavirus, we immediately started partnering up with faith-based institutions, churches, to make sure that we were not only connecting people and understanding about the testing, but that we were able to also distribute HIV information and HIV testing, self-testing at the same time. We immediately connected our self-testing program to our telehealth program so that we could, and we repurposed, repackaged, and rebranded the OraSure kits so that they looked like Sister Love when they came to you in the mail, so that it was already a familiar source that you could call us. It actually had like that Alice in Wonderland, like, drink me kind of note, where on the box it says, call this number first, and we will walk people through that process. We are now, 2 years in and later, also directly involved with those same faith institutions around getting our people vaccinated for COVID-19, against COVID-19 or the coronavirus. Bottom line is that what I want to talk about last, before Kirk takes it on, is that aside from all of those challenges and all of those problems, what also showed up happening is that once Black and Brown communities got involved, we got people tested more in our communities than anyone else could. Aside from that, or in addition to that, we've also been, I think, the most trusted source on educating people about the vaccines, about HIV, about how these things happen in our bodies, and why the science is so important, and that we can relate based on other conditions and experiences. The fact that we are in a racial justice so-called reckoning still ongoing, some of us have been smart enough to take advantage of that and say, hey, the police brutality issue is not the only way that violence is being conducted against our community. Let's talk about the neglect around coronavirus. Let's talk about the neglect around HIV. Let's talk about the othering of Black-led community-based organizations. So using everything in our arsenal to fight racial injustice and discrimination is still going to be our best bet to ending HIV in all of its formations, in all of, whether it's research, whether it's treatment, whether it's prevention, whether it's care, whether it's advocacy. All of it is based on human rights, and all of it is based on how we fight racial injustice. That is really the crux of all the conversations we need to have, including how this work gets funded.
Thank you, Dázon. Kirk?
All right, so what was the question again? I want to make sure that I give a whole nother perspective after following these two beautiful women.
Yeah, really, from your point of view, how COVID-19 has impacted the access to HIV services and care, from what you've seen with Abounding Prosperity and your work down in Dallas, Texas.
So, and I was just having a call prior to this one. And so we, as oftentimes we find ourselves, we have been in a unique position. So where, and there are several access issues that have already been addressed here. And so ditto to all of those. But for us, it was a bit different because the county took an unusual step and deemed us essential, the whole organization, essential workers. So while other organizations that didn't look like mine, that weren't minority led, were able to close and certainly took advantage of it. We were still on the front line as we always have been. But what we noticed is we had to take on a whole nother role. So we were the source of information, the source of consoling and all of these other things that, when they talk about one-stop shops, they certainly don't include all of these other additional things that the community counted on us to do. So initially, one of the very first things we had to do was address food insecurities, the transmission of COVID. So we provided care kits, prevention kits. So, we had prevention kit to prevent COVID that included gloves and soap and all these various things that we knew at the time, the masks that prevented COVID. But then we also had kits that had vitamins and all the different things to treat those individuals that had acquired COVID. So that was our very initial response. But the other thing was we worked closely with the USDA program. They were doing food boxes. And so for the first 2 months of the COVID pandemic, we were doing COVID food kits and prevention kits and care kits. And then the other thing was people were losing their job. They weren't going to work. So we were giving out $150 gift cards. We did that again. That extended for the first 6 months. So again, those were the things we had to do to continue to support and or stabilize a community that certainly experienced major disruptions. And then on top of that, we continued to provide care. There was never an interruption in care, but we were ahead of the curve. This is where we were unique. We already had a telehealth platform that we defined, because people are using telehealth as a catch-all. And so for us, it was more defined. We had telemedicine and we had telescreenings. And so to Dázon's point of sending out test kits, not a fan of sending out home OraSure kits. So we figured out what would work best for our population, because we didn't want people lost to care. So we send out kits, which is why the telescreening platform was important for us, is that we will pop up just like we're doing now. We'd walk you through the screening. The results were sent back to our lab. So then that way we would know if we needed to provide additional follow-up, if it were, a positive or a negative. So that way we didn't have a lot of people that are aware of their status that was still a potentially never in care. The other thing that we found that they both have already, the two ladies have already identified, was again, inequities around, systemic stuff. I'm not going to go into that. I think it was said eloquently. But one of the things that I personally had to do was say, hey, Miss County of Dallas, what you're going to do is have some Black vaccination sites.
Right.
That was a problem. They were not vaccinating in communities. And so we they had all of these hoops that you had to go through. You had to have sites where people can drive through and all that. Well, lo and behold, we had those sort of facilities. So we had facilities where we could host vaccination drives where they were doing mass vaccination. So again, one of the things that we experienced in Dallas, just like other communities, that the vaccination sites were inequitable in the way that they were distributing the vaccine, even when they had elderly and all of those days. It typically were people that didn't look like any of the folks that I see on the panel. And so, having to do that strong advocacy, you designate us essential workers, but again, you're not putting vaccines in our community. So, and not only that, but having to do the necessary educational work. Y'all said that again, people had, mistrust and all of that of the vaccine. So educating communities around what that looked like. But again, having the initial lead in gave us a lot more viability, rapport, and believability around, talking about accessing vaccines and how they could help prevent the spread of COVID. And the last thing is just continuing to walk people through. We continue to provide care provision, testing efforts, all those things. But now the flip side, well, all these other organizations that closed, well, people had problems with access. Our county was solely focused on vaccination efforts, whether it was DIS, it was all hands on deck. And so in that regard, what they did do that was unique once again is they were referring all STI, all county services to Abounding Prosperity. So we were, but it was still an issue. You only had a portion of those people that would take the referral and came over. So you still had all these individuals that were lost to care and are lost to services. And so we know that testing was impacted. Access to PrEP was obviously impacted as well, but also access to HIV care as well. But one of the things that we haven't talked about, I haven't heard in a lot of these is, our target populations are our populations of focus are Black MSM, Black women, and trans women. And we talk about the loss of care, but a lot of the trans women also lost their hormone replacement therapy. So, that was certainly a big issue around accessing care as well.
Thank you for lifting that up, Kirk. I think it's clear that organizations, particularly community-based organizations that were situated to do HIV and AIDS work, had to completely shift to do COVID-19 work while still meeting the needs and the demands of the HIV community, which sometimes were the same communities, right? I know even for me, UBtheCure, immediately we had to shift to COVID-19 work just to meet the need. And it took so much time and effort away from our HIV and AIDS efforts. And so now the narrative is, how do we get back on track? We've seen metrics that suggest globally that the COVID-19 pandemic might have cost us 5 years of progress in ending HIV and AIDS globally. We don't yet know what that might mean for us here in the United States, but based on your own perspectives, I think we have a pretty good idea that we treated COVID-19 at the expense of HIV and people living with HIV. And now there's this deepening conversation about how it is that we get back on track. Considering what you all have seen, considering where your organizations are now in the midst of both COVID-19 and HIV and trying to continue to meet both of those needs, do you all believe that we are still on track as a country to meet our 2030 goals of ending HIV as a public health crisis?
I honestly think we were, I was gonna say, I honestly don't think we were on track before coronavirus.
Before.
Okay.
And we were really never on track simply because the plans never, at least up until the most recent updated national strategy, and even then it does it really, really minimally, was to address the unique issues. I mean, a part of the reason, one of the conversations we're having around funding is, for example, we can go back 30, almost 92, 94, whatever, we got the Minority AIDS Initiative initially passed as a part of the Ryan White Care Program, that we never saw that money. We never saw those resources. We never saw the intention of that original funding to come to build the capacities that our organizations needed in the first place. So that was already a setback, that we never were truly on track to get to the end of the epidemic. And let's say this, I do think that white men are on track to get to the end of the epidemic by 2030, probably worldwide. Worldwide, Black women are the last on the track, including looking at all of our experiences and identities, transgender women, trans experienced masculine people who were assigned female at birth, for additional reasons around sexual and reproductive health rights and security and safety that matter. We're not on track when you still have housing disparities, redlining and discrimination. We're not on track when you still don't have those resources coming to build those capacities. We're not on track when you still don't have enough Black people who are engaged in the research to start with, right? So we're not on track if we have not incorporated a full social and racial and reproductive justice agenda as a part of the biomedical prevention and treatment agenda, that those things have to work in concert to get us to the end of the epidemic of HIV. I'm the co-chair of Act Now End AIDS Coalition. We actually published and put forth a national strategy to end the epidemic by 2025 back in the 2010s. When we did that, it was with the effort to incorporate all of these conditions and issues that we had to strive for together in order to achieve it. And we knew that we could have been on track for 2025, but for the sake of coronavirus. I think the other thing we have to point out that has set us back, and I don't know about how many years, is the fact that with the advent of organizations like Abounding Prosperity and Sister Love having to pivot and shift, because the HIV community was the go-to community on how to respond to coronavirus in the first place, from the scientists in all of the public health spaces to what was happening in the industry and the pharmaceutical spaces, to those of us who are doing HIV work on the community level. Every sector of HIV was sucked into this coronavirus response, right? And they are just coming back into the field. So into HIV focus. And so I think that we might find ourselves set back further. There is data that shows us that from a prescription standpoint, from healthcare, insurance data, so this is the consumer utilization data, that, and only the insurances and pharmas know this kind of information. Takes the public health system 3 years to get this kind of information. But the fact that HIV testing dramatically dropped during the first 18 months of coronavirus, but that when we came back, and Georgia is an example of this, when we did come back, we are not yet back at the same numbers of HIV testing, but we're almost there, believe it or not. We are almost back at the same numbers of the level of testing as we were prior. The yield, however, in terms of how many people living with HIV we're finding, is way above the numbers compared to the numbers of people tested that we knew before. And those folks, simply because of access, information, the stigma, all of that stuff, that we have even more people who are being diagnosed with stage 3 HIV disease at their first HIV diagnosis than before the coronavirus. So that tells you that as we're continuing to do this work around coronavirus, we're not going to be in a position to pivot back to where we were. We're going to have to be in a position to keep going forward. And as Kirk already lifted up, while we might have been cost 5 years of progress towards the end of the epidemic, or progress with ending gender-based violence, for example, which I don't think we were anywhere close. So whatever we've lost, we're just even further behind, because the lockdown also showed us a dramatic increase in gender-based violence across the genders, actually. Is that what we also need to put our eye on is that while we were slipping backwards in terms of progress, technology and science was leapfrogging ahead, right? So they actually found at least 10 years of progress in technology that they had not expected to have to achieve. How are we building ourselves to take advantage of that technology? How are we interrogating that technology in a way to determine what's more dangerous for us because of that, or what's more advantageous to us because of that? And that includes the telemedicine world. It includes the meta universe, quite frankly. I'm not surprised, and I'm going to close on this one example. Voting matters. My friend Nsé Ufot, who just stepped down as the founding executive director of the New Georgia Project, who was one of the signature organizations responsible for flipping the Senate in 2020 and 21 because of January 5 and 6. But also during that time, they actually invented a game. It was an online game, in the metaverse, that was all around voting, using our own images, using our own culture. It is now it's been adopted into Google Play and into Apple World or all of that kind of stuff. I'm not as adept as I should be on that technology, but it's now a part of the gaming world, organizing Black people to vote. So when we talk about the losses that we have suffered or the setbacks that we are experiencing, we need to also be focusing in on where others are advancing and taking advantage of these moments and how we are doing the same. And I think that should be a part of our clarion call when we're talking about how we deal with the funding issues, how we deal with the information sharing, how we deal with the equitable distribution of where the services are and how they're located, and how we make sure that we're valuing people's everyday lived experiences as the data that we need, the stories that we need to inform the way that we can respond to people or even be more proactive in terms of preventive health.
Thank you for that, Dázon. You talked about resources and funding more than once, and I want to pivot to that conversation, understanding that funding is the key driving factor in our response to HIV. Sister Ya, I want to get your take from an epidemiologist perspective in terms of where you think we are in meeting our 2030 goals. And I saw a lot of agreement with Dázon's comments that you were making, but I also want you to talk about your work specifically in the state of Illinois around lifting up inequitable funding allotments towards Black-led HIV service providers as a function of our progress or lack thereof to meeting our 2030 goals.
Yes, thank you and appreciate that. So I'm just going to delve right in. If you don't mind, I'm going to share my screen. Hopefully people will be able to see it and I do this correctly because I'm always confused, but not always, but so I just wanted to show people that the, well, I was going to show them my article that so they could see where I started with this whole aspect of, you know, we have inequities as far as funding is concerned. So I was able to publish and I'll just take this right out. I was able to publish an article in the Journal of Healthcare Science and Humanities. Shout out. This was a special issue that was only for HIV/AIDS in the Black community. If you haven't been able to get this, contact me and we'll figure out a way to make sure that you can get it. But they are charging for the book, but the articles are free. So I am able to show my article this way and you know, making sure that to the fidelity of the journal publishers. But what I was able to talk about,
we can't see it. All we see is the top of your screen.
You can't see it.
I don't know if you can scroll down.
Do you see anything here? Do you see?
We don't see the figure.
We can see your
the top of your screen, but we don't see the figure.
Okay, I'm gonna try this one more time. Hopefully it works. Can you see anything?
There, yes.
That's okay. Better.
I'm gonna leave it here because I know nothing. I don't want nothing to go wrong. Is that so? You see some bars, right? You see red, black, and green, right? So we at least you see the chart. Let me just, because of the time, I'm gonna go right into it. So in this, Illinois, we have the Illinois Department of Public Health, we have the Chicago Department of Public Health, right? So we're just gonna call them the local health departments, the state and local health departments. They get, you all already know this, they get federal funding, Ryan White, okay, federal funding to work with people who are impacted and affected by HIV. We know that that's been going on for years. What I was able to really hone in on was the inequitable allotment of funding that went toward Black-led agencies in both, you know, city and state. So this chart was really to tell you, okay, if we look at Illinois, where Black represents, represents obviously, you know, new HIV cases. You can see the red is living with HIV cases, and of course the population. So all of those things aren't new to you all. We know that Black people have the highest numbers, no matter, you said that already, Dr. Ulysses. So it's the same in Illinois. We just got that 50% and over, right? Of all either new cases or living with prevalent cases. And of course, our population sizes, as you can see in green, are always smaller. For Illinois, we're 15% of the population Black people. And for Chicago, we're 30% of the population, which actually a lot of people think that that's It's decreasing. But the point of it is these little boxes at the bottom. Now, I know your eyes are like, what is these little squares? What are you doing down there? This was where the crux of the matter was. That's the funding, y'all. No matter what you pick from the state to the city, right? The Illinois Department of Public Health had their funding allotment, and the Chicago Department of Public Health had their funding less than 1%, and for Chicago was less than 4%. Now, why is this important? Because graphics has never been put together before. If I tell you the population of the people that exist, if I tell you those who are impacted, affected, have HIV exist, and I tell you more importantly, whether there's a new cases or existing cases, but then when it comes to the funding, we ain't even close for Black-led service providers. That's a problem. That means that the white-led service providers who've been getting the funding all the while, our numbers are still going up. So who's being efficient or effective? It's not to say that they can't serve. I'm asking why Black-led service providers cannot serve. Why is it when it comes to the money, we can't be as represented as we are in the number of cases that we have? We can't even get to the construct of where is that money going to, and it ain't going to Black-led service providers who are qualified. I did not use any data of any service provider who was not a qualified candidate. What I did was able to demonstrate that even of the ones who got funded at the level they got funded for. So these are the ones that did qualify and make the cut. And it still was less than 4% for the city and less than 1% for the state. And we're talking for the state, $40 million, for the city for the state was like $15 million. And for the city was like 40 million. And even if I don't have the exact millions of dollars, I'm letting you know of any of the money that they got in for the 2020 round. And that's what I'm referring to, 2020. This was the percentage that the Black-led service providers got together, 9 service providers collectively. So you're probably going, yeah, that's not true. It's true because even their own people put the data out. This is from the data comes from the actual funders themselves, from the city and the state. So when I was able to put this together, my colleagues were very, very upset, and they ended up forming a group, that we called ourselves the Black-led HIV Service Providers Group. I didn't want to get into all of that, but what has that done? That was able to bring forth and shine the light on the inequities, the funding allotments that were grossly undermarked. More importantly, at that time, they were going to take away the African American Response Act. You all may not know, in this state, the state legislators and others got together and created a response act just for Blacks. They were going to take the money and give it to white-led and other Hispanic-led organizations because they're saying nobody's using it. We're saying you're not allotting it to the people that need it. This was mind-blowing to me. So what I was able to do was look at this data itself. This is what data, I speak data, but I'm able to say the narrative on where the data matters. It mattered because if my numbers among my people are going up, but the numbers of funding toward the Black-led service providers is not even appropriately being allotted, then why do you expect me to get better? It's not following logic, nor is it following science, or for that matter, following the data. So I don't want to spend a lot of time on it. If people have questions, I can answer, but I really just wanted you all to know that if we didn't do anything else, and this is the Black Leadership Advocacy Coalition for Health Equity, we call ourselves Black, we were able to get back money from the state that was going to eliminate the African American Response Act. Zero budget. It was zero in the budget. But because these specific people, Creola, Hampton, and others that are part of this Black organization, because we got together and put such a voice down we was in state reps' faces. They funded it back to 15 million, hopefully 20 million, and we're still fighting and we're still trying to get it allotted correctly. But that whole African American Response Act now has to go 100% to only Black-led service providers. So if we didn't do anything else, we at least tried to hold on to some money that should have been ours in the first place. But the mindset behind this is unconscionable, as though we're speaking a foreign language when it comes to comparing white-led organizations funding to Black-led organizations funding. It is not equitable and is not following the science. And we want to know why the federal government is still allowing them to get this type of money and not be held accountable or have repercussions for how it's being spent. I just wanted to share that. I can't do my whole article, but this is the crux of it right here.
No, and I think that's important. As a Chicago resident, as a leader of a Chicago-based HIV and AIDS organization, I can speak directly to the advocacy work of Black in increasing the budget from $0 in 2019 to $15 million that would go to Black-led organizations. And we want to be clear that this isn't an issue isolated to Illinois or Chicago alone. I know that both Kirk and Dázon can speak to the funding issues in their respective states and cities and the ways in which they are advocating for increased funding at the federal level through Congress. So let's talk more about that. Kirk, how have your HIV appropriations requests to Congress been going? What are you asking of Congress in terms of supporting the role of community-based organizations to get the nation back on track to end HIV by 2030?
Okay, so, well, first of all, I have to go back. We talked about ending the epidemic by 2030. Again, I echo Dázon's sentiments. However, I mean, she covered it great, but I want to talk about, but we are poised. So before I talk about funding, I know my organization and maybe many others like mine, you know, it used to be that often in the Black and brown communities, the church, you know, whether it was the Black church or the Catholic church, you know, was the center of information. Well, that's been a shift, you know, so at least in this community where I serve in the South, we were the repository of information and services outside of HIV prevention services. So I think we are uniquely poised, because you have to be poised. You know, and one of the conversations I was having with someone from CDC yesterday to answer your question is that a lot of these organizations that don't necessarily look like the populations that they serve are not poised. They're not poised, rapport building. It would take them that many more years to build rapport, build some of these capacity things that are not necessarily structural, that to be able to end the epidemic, but also address in ending the epidemic, because I like what Dázon said, it's going to be ended for some in maybe around that time, but not for others. So I'm going to adopt that, girl. I like it. So obviously there's going to be a need for increased funding because we've, you know, again, all the things that when I'm talking about $150 gift cards, you know, none of our funding sources covered those things. So we had to use reserved, unrestricted dollars, those sort of things. So, and we need to look at funding differently. So we need to look at those support services that need to happen as well. I mean, again, if I'm still impacted economically because of COVID, because, you know, I was a gig worker, the gigs never picked up, or any of those things, my job, I have another job, but it's through a temp service. I don't have insurance now. All of these issues that now still they expect organizations like mine to address. So we not only need more funding, but we need funding. I think Dázon talked about this earlier, but we need funding to address those ancillary things that are needed to even start having the conversation about HIV prevention. And lastly, this was touched on, but you asked what I've been advocating for. Again, research, you know, 096 is out and we're one of the pilot cities. And once again, you know, I've had to talk to people that didn't look like me about how offensive some of these things were coming into communities, and the same old that you're taking more from a community than you are leaving the community with. And so having to still have those conversations and battles in 2022 for me is nonsensical, you know, but we don't have enough, you know, when we start talking about NIH funding. So these are not necessarily minority-led efforts, but again, you have these folks that, are coming into these communities, have no idea, not poised, I like using poised right now, are not prepared and don't have capacity. And then they come, but they're supposed to be, providing answers to questions that oftentimes communities have those answers. So I do think that there should be more funding for community-based efforts. I think that community-based efforts oftentimes have a capacity that just a lot of these entities don't. Let me talk for example, our FQHC that's less than a mile from us, they keep talking about, well, the FQHCs can do all this stuff. Well, our FQHC has said, we don't have expertise. Said this in the public forum. We don't have expertise around HIV, the provision of HIV services. And I'm like, well, now, girl, that's contrary to what they're trying to push on us. So again, making sure that there's more funding I've advocated for more funding for community-based organizations such as mine, because again, what we have found clearly is that they weren't going to FQHCs, they weren't going to these county hospitals, they weren't even going to the county STD clinics. They were coming to our little friendly clinic in the hood, access to, hey, what do we do? My grandma and them sick, my mom and them, what do we do? Da, 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 da. So it has to be not only expanded funding, but funding that touches on the myriad of issues that we've talked about today.
Dázon.
So what we're looking at, and I want to give great credence to not just what the data tells us from what Yah has presented, but also how you have to use the data to affect change. That's, I think, a core piece in our work that we have to continue to understand. And so when we talk about what are we asking the funds for, well, we've already talked about, we understand the epidemiology, we understand the somewhat skewed view from the surveillance of HIV in our communities, and the funds don't follow. But here's the other aspect of it, and somewhat the same kind of argument we've been making around women in HIV forever, which is when it comes to Black people, especially when it comes to Black women or Black and brown people who are LGBTQ or gender identified as female in any particular way, is that HIV cannot be treated as an exceptionalist issue. It is a part of a family when it strikes our families. It is a part of our community. It is a continuum of not having enough education and information about our health overall. It's including our sexual health. It's not enough to only talk about HIV or to screen for HIV or to treat for HIV in our communities without addressing some of the other conditions and health problems, including our mental and behavioral well-being. It's not possible to achieve that. And that's why they keep trying to throw it after FQHCs, because they're supposed to be the catch-alls for all of these things. The thing is that they aren't, and because of HIV stigma, discrimination, or because of what's been set up by HIV exceptionalism, which has had its place for all the right reasons for all this time. But trust and believe, I say this all the time, if this virus had showed up in anybody's or recognized, let's say recognized, because it showed up in Black bodies, it just wasn't diagnosed. If it had not been recognized in white cisgender male bodies, we would not be sitting here 40 years later talking about an entire industry around HIV, around how many billions of dollars are going into the discovery of a cure, or any of that. We wouldn't be here. We'd just be talking about, ooh, them poor Black people still dying disease. That's what it would be called. So recognizing that it will be more expensive. I'm not even going to argue with people anymore about equitable funding. It's never been equitable in terms of how Black people's well-being has been resourced for over 400 years. So I don't need to use the R word to talk about how the funding and the resources actually need to be unequal at this point, need to be distributed more into communities that have gone without for longer, need to be given to community-based organizations that understand our people, need to be given to people like Abounding Prosperity for whom the whole government in the Dallas County and Texas area, local and state, have said, oh, go see the Black people because they're taking care of y'all, without giving the appropriate resources to go with that. That's what has to change here. And that's why, for example, this request, this ask of a piece of work at the legislature to look at increasing the funds that should be targeting the epidemic where the struggles are still the most dire, where the conditions are still the most disproportionate, that should be considered a no-brainer. And if you needed to be rocket science, then you talk to people like Ya and Dr. Ulysses. But from a common sense standpoint, you know, it's similar to how we're looking at the situation in the Eastern Europe versus how we've addressed some of the issues, whether it's in Yemen or whether it's in Palestine or whether it's in Ethiopia or other places where conflict has directly impacted Black or brown people, especially as women and children. But all of a sudden, because it's Russia and it's the Ukraine, and I understand because there are, you know, white-led countries, white predominant countries that are also a part of this global political, you know, geometric military kind of framework. Yeah, they have that level of impact, but that also speaks to white supremacy. And the fact that white supremacy is what's driving all of these disproportionate experiences has to be paid for. It has to be repaid. It has to be prepaid. It has to be done in a way that acknowledges damage done and repairs that need to be accomplished in order to achieve the health ends that we need to get to. I'm not going to be apologetic about talking about this in this way anymore. And I don't care how uncomfortable or fragile people might feel around this conversation. If they are honest brokers in human rights and the health and well-being of all our people, including our Black and brown people, especially our Black folks, if they're honest brokers, then they will come to the table open to hearing what the real solutions are, and they will put the money in that direction.
Dr. Ulysses, I know you got to go. We only got a few minutes left. In fact, we're out of time, but I have to tell you that yesterday, Admirable Collins, she's from the Minority Health Initiative. She was on the line with the National Academy of Science, Engineering, Medicine. I'm a little bit a part of them, but the point of it is they are saying that the federal government policies are inequitable. And they said, what can we do? Or they're saying, how do we address federal policies and programs that continue to make people inequitable, you know, that continue to drive health disparities, if you will. And the point of it is that's people continuing the same old malarkey and then want to turn around and ask us what we should do. I'm like, why don't you spend the federal money, because that's our money, correctly, based on what we asked, not what you told us. That is where the problem is. And until we, you know, nothing is going to get done without a demand, but we got to bring thunder.
And we need to have a conversation about what tools there are, because that's the other thing. There are tools that other people learn about and get to use to their advantage that are not shared. And then we don't, one, either learn about it, or as Kirk was saying, build the rapport, have the positioning and the relationships with the inside intel to know how to access those tools and to use them. Health in all policies is one of those tools that the CDC holds, that if it's not being applied appropriately, we should be fighting to make that appropriately applicable to our community. If you're creating policies that create further disparities, then that has to be dismantled immediately.
Thank you, thank you, thank you. I think that's a wonderful note to end on. I would ask that all of our panelists would put your email addresses in the chat box in case people want to continue this conversation with you, especially around the ways in which they can be involved with rallying our congressmen and women to increase funding around HIV and AIDS. I want to thank the National Minority Equality Forum for always hosting such important and critical conversations with the best persons in the country to have these conversations. And I want to welcome each and every one of you back here on Fridays for more engaging conversations throughout the rest of our summer. I'll turn it over to Brandon for any final remarks, and God bless.
Well, thanks so much, team. It's always good to just get this very direct and honest conversation out there and let folks know what needs to be done and what you're thinking as well. Just giving it just a couple of minutes just to make sure you all were able to insert your email addresses for our audience. So I appreciate that. So audience, please take hold and give them, as you've seen, they will let you know what you need to do and what needs to be done. And with that, I just want to thank you all again for your just time and thoughtfulness. And I think this conversation was very appropriate and timely. And look forward to seeing you all again soon. And obviously, as Dr. Burley mentioned, we will have these conversations throughout the year. So we look forward to seeing you next week, same time, same place. So have a good weekend, everyone.
Excellent.
Thank
Happy
you, guys. Yes.
Juneteenth.
Yes.